thank you for the opportunity to speak here. I'm going to talk to you about adult ECMO, conflicts of interest. I've been an advisor on the OLEA trial, advisor on some product design for McKay as well, but I have received no money on this, and Jay Swishenberger, of course, loves to give me grief about this. He said that I should actually get paid for something. So ECMO in a nutshell, you have an oxygenator, you've got a pump, you have your blender. You take deoxygenated blood out of a patient, you return it oxygenated, and you've swept off the CO2. Two cannula versus single cannula, very popular to use a single cannula at this point. I won't go into every different cannulation type, but you can use VV ECMO, you can use VA ECMO, you can use central cannulation, percutaneous, and so forth. So a quick overview of what I'd like to discuss. This grew out of cardiopulmonary bypass. I'll give you a start with our interesting case report. The abysmal failure of ECMO, a little bit of glimmer of hope over time, some hope and hard work, where we are today and where we're going to go in the future, I think. So, there's a spectrum of extracorporeal life support, all based off of cardiopulmonary bypass. And, we have veno-veno, a veno-veno arterial hybrid, and strict veno arterial. You can also do AV approaches. But it depends on whether you're looking primarily for pulmonary support or cardiac support or some blend of that. And of course, there's different approaches. The central approach, whether you use a PA to LA, where you're using the right heart to provide the pump. You could also use a right IJ for venous drainage, and then a subclavian artery approach with a graft on that. So let's start with the interesting case. 1972, New England Journal of Medicine, Don Hill presents the use of ECMO for a patient, a polytrauma patient. 24-year-old man struck by a car, subadventitial tear in the thoracic aorta, multiple bone fractures, develops ARDS postoperatively. So there he is. Bob Bartlett provided this photo. He provided a lot of other things for me, and I'm indebted to him on a lot of levels. But here we have Bramson membrane heart-lung machine, support this patient for 75 hours. Then in that case report, they sort of snuck in a second case report about a patient with a fat emboli that they treated as well. So this is 1972. As you know, not much happened after that very successfully. Of course, the ventilator management at that time probably almost killed this patient. It was probably the reason why he needed the device in the first place. But that was 1972. We didn't have the ARDS-net protocols. They were ventilating at greater than 12 cc's per kilo. PEEP was limited to 8 because everybody thought PEEP was bad in that situation. But again, 1972. So what are we trying to prevent here? Hyperinflation of the lung. You can see that you create tears in the membrane. You can shear epithelial cells off. We already know that there's a lot of ventilator-associated lung damage in those cases. And in this CT scan, you can see a region of preserved lung. Gattione talks about the baby lung. Most of this lung is not functional. You start putting in high pressures, high tidal volumes, and what you do is you just extend the injury for the remaining good lung. So there are a lot of trials, a lot of case reports, probably the three that are most relevant to this discussion, the early NIH studies, and then the CESAR trial. So in the NIH ECMO trial, 1979, if you had ARDS and you were on a ventilator, you died. And if you had ARDS and you were on a ventilator plus ECMO, you died. This study had a 90% mortality. So what went wrong? There was a bad flu that year. There was also a lot of case mix problems, and then excess of blood loss. They were transfusing patients up to 2,500 cc's a day in blood. Not appreciating fully the trolley effects of that. And a major problem with these studies is many of the centers that were involved had no prior ECMO experience. Lung rest concepts were not very well developed or appreciated. There was prolonged pre-ECMO support on a ventilator, and this is a critical concept. Really not, it was not very well appreciated even until just a couple of years ago. Using VA bypass and reducing pulmonary blood flow is a problem as well. Then we have Morris's ECOR study. Again, the problem of having patients on the ventilator too long before intervening. Again, very high blood loss with huge transfusion requirements up near 3 liters a day. And there was no substantial lung rest that was achieved in these studies. They still had peak inspiratory pressures in the 50s. Very little experience with the centers, and many of these patients were enrolled in criteria that were probably quite compromised. So the University of Michigan published this study looking at 36 of their patients that they used extracorporeal life support on, and they found LD50 at 5 days, LD90 at 12 days, and in a lot of studies now you'll see that transition point is somewhere around 7 days for effectiveness of intervening. Otherwise, you're going to have a certain amount of irreversible lung damage. And we have the CESAR trial, and I'm sure many of you are already very familiar with this. I won't spend too much time on it, but a key important point here is reversible acute lung injury. And just a quick review of the Murray score. If you take a look at the ELSO national database, these numbers all cohere, about the same P-DAF ratio, peak inspiratory pressure, so forth. And exclusion criteria, 7 days. So not a small point about this. And irreversibility is a very important point for exclusion. If you're going to take a bunch of patients that have end-stage IPF and they have an acute decompensation, you put them on, I can tell you your outcomes are not going to be very good. There are 180 patients enrolled, 90 in the conventional arm, 90 in the intention to treat. Not all 90 in the intention to treat received ECMO. The bottom line is death or severe disability at 6 months. There was a statistically significant improvement with patients using ECMO, but if you took a look at died within 6 months or before or discharge, then there was no statistical significant difference there. What's important to note here is that 3 patients that were enrolled in the ECMO arm, there was only one ECMO center, they were transported on a ventilator. They died en route. If those patients had been put on ECMO there and transported on ECMO, if 2 of those had survived, that would have been statistically significant. There are a lot of other limitations to this study, but important to note. Toronto published on the 4 of their patients that used PA to LA, and we've done this several, a couple centers in Germany have as well. This is what you would use for a bridge to transplant patient. You can mobilize these patients reasonably well. Looking at ECMO as a bridge to transplant, this rough summary of a lot of the studies out there. Bottom line is that 1-year survival in these studies ranges somewhere between about 60 and 80%. So Mason looked at the data from UNOS 1987 to 2008, ECMO versus mechanical ventilation versus patients that went to transplant that were not supported by some type of device. The bottom line is not very good numbers, and those numbers do not get better. They do not level out. They continue to have worse outcomes. So why are we doing this? Well, in the bridge to transplant patient, it certainly allows for maximal physical therapy. Most of these patients are very deconditioned, allows us to optimize their nutritional status, really work with them, and avoid ICU polyneuropathy, which is quite common once they deteriorate to that end-stage lung disease state. But the central question is, are we improving these candidates, or are we just actually facilitating the ability to transplant very sick patients, maybe that shouldn't be, and then they have poor outcomes? This led us to certainly reevaluate what we were doing with our criteria and the way that we manage these patients. We want, obviously, a near complete or complete transplant evaluation. A lot of these patients come in, they're in bad shape, and young kid, everybody wants to do something for them, but they haven't had a good transplant eval. It's usually a mistake if you follow this pathway. Obviously, they have acute decompensation on their chronic disease. You want to make sure that they don't have some type of extrapulmonary manifestation of problems. And the real key here is early intervention or no intervention at all. So this is our experience now. It's actually 18 patients, 14 VV, 4 VAs. We've transplanted, actually one of the patients is going to transplant right now, so it's great. I'm in California, and my boss, Josh Sonnet, is doing the transplant, and I love that because usually that's not the case. So 3 of these patients, we actually bridged to recovery and went on. 2 of those got transplanted. 1 died about 3 months later of a bad pneumonia. Median duration for those that went to transplant was 6 days, but we've had patients on for up to 31 days that went to transplant. We have 100% survival for those patients. They're all at home. And you really have to take care of these patients physically and emotionally. You exercise them and let them stay connected, literally. And this is with a single cannula. That's Dr. Oz. We have Dr. Oz, so we have him see all of our patients that are being bridged to transplant. Apparently he still works at Columbia. That's the report. So this is one of my patients I transplanted about 3 years ago. She loves to send me these pictures of her oxygen saturation. I'd every so often go to the email and get a picture of oxygen saturation. That's Salim Arjasoy, who's our medical director of the transplant program. This was when she was climbing in the Austrian Alps last summer. So what are we trying to achieve here? Ambulatory ECMO, a high emphasis on this. This is a young man, pulmonary hypertension, class 4, couldn't get out of bed except to go to the bathroom. We put him on VA ECMO. He's got arterial return is through a graft that I put on the subclavian artery, and then I cannulate that through a tunnel cannula into that graft. So this guy went from being bedridden in 10 days. He was up to walking 1,000 feet a day. We gave him a stationary bike. He was riding a stationary bike in his room twice a day for 20 minutes to try and recondition him. We also use ECMO as salvage therapy and primary graft dysfunction. And we've transitioned really to veno-veno. Some of the veno-arterial reflects older data, but we have a better than 90% survival rate even in severe primary graft dysfunction for patients post-transplant. A lot of these concepts really come from LVAD data. The key is you need to intervene early. You have to intervene before they have a worsening nutritional state, before their end organ starts to fail. I have a patient that's in the ICU right now that I'm bridging. She's a PH patient, 35 years old. She was about to go on dialysis. We put her on same configuration, subclavian artery, right IJ. She's up and walking. Her creatinine's normalized. She's eating. Now I just need some lungs for her. There we go. Okay, so at ECMO, at Columbia, over about the last 2.5 years, we've done almost 200 cases of ECMO. About 40% of those have been for respiratory issues. The others have involved post-cardiotomy issues and cardiac applications. I'm going to slice out a component of that called the medical ECMO program that I've developed with our head of our pulmonary ICUs. And we've done 50 cases over the last 3 years, 8 so far this year. We've also developed a transport program. We've done 24 transports with an effective ground range of about 150 miles. So what are we trying to achieve here? It's ECMO versus mechanical ventilation. Obviously, the potential benefits are the elimination of positive pressure ventilation, avoidance of deep sedation for those patients, the ability to participate in physical therapy, and reduce neuromuscular complications, which really carry a long-term morbidity for these patients. There are risks. There are risks specific to ECMO, bleeding, thrombosis, so forth, but with the technological advances that we've had over the last couple of years, those have been minimized. We also keep very tight protocols on anticoagulation and transfusion requirements. I'll try and get into that a little bit. So this group, we're looking at hypoxic and hypercapnic failure for patients, but they also have to fail ARDS net protocol. We don't just throw everybody on ECMO. We try a lot of different things. And we don't do prone positioning at Columbia anymore. We've tossed that out. We don't use nitric. We don't do a lot of those things. You either get fixed on low tidal volume, low pressure ventilation with correction of your volume status and other types of support, or you're going to end up on ECMO. So for our hypoxics, these are our criteria. Now we say P to F ratio less than 100, but actually in our case series, it's closer to 50. And I don't think anybody would put somebody on if they had a P to F ratio of 90, although it may come to that someday as our results improve. Key is reversible causes. Make sure you have a reversible cause. Know why you're going on, what you're supporting. For hypercapnics, a pH that we just simply can't correct, it's hanging out in 7.2 and an increase in the inflation pressure. So relative contraindications, there really are no absolute contraindications, but you really need to think about that. Again, avoid the irreversible conditions, otherwise you really need to be talking about bridge to transplant, which is a separate management pathway. Other documented irreversible brain injury, you wouldn't do this for a patient with stage 4 esophageal cancer. Irreversible multi-organ failure. Other relative contraindications, I keep mentioning this 7 days. Now, it's not, is 7 days, was that put into stone someplace? No, it isn't. Really, you're looking at an area under the curve. You're looking at pressure on that lung, on that injured lung over time. So have we violated this? Yes. In fact, I've violated essentially all of my relative contraindications at some point. About a week and a half ago, I transported somebody that was just over 125 kilos. Now he's extubated and he's off. But that's, we violate these when we think it makes sense to do so. Day 0, right? We just put the patient on. You can see that he's got a cannula right here, bilateral infiltrates. So you've all seen these x-rays. Day 8, we can see clearing of the lungs, and this patient's ready to come off, and we got her off. But what does this look like on CT scan? Again, this guy virtually has no lung left. He was a young guy, about 42 years old, bad pneumococcal pneumonia. We transported him in from another hospital. He has a single cannula that we used, Veno, and he is back to work, recovered very nicely, and you can see on his CT scan here, 4 months later, no scarring, his PFTs are normalized, and he's doing quite well. So other data that we're tracking now is looking at the effects on pulmonary compliance while we're supporting patients with ECMO. This red line up here is the ARDSNet data. You can see that there's no improvement in compliance, even using ARDSNet protocol. It takes quite some time for these patients to recover. We're able to reduce those pressures and tidal volumes quite significantly when we're on support. It allows us to push lung rest to a new level. And what we've seen is, a 30% improvement in the compliance over the same period of time. And our patients are quite actually sicker than the average sort of ARDSNet data patients. With our current protocols, we have a 90% survival with severe ARDS and the P to F ratio around 50. It's actually, I think, 52.5, but who's counting? So ambulatory ECMO, this is where we're at. This is a patient, we're running a Hypercapneic trial at Columbia. This is a patient who the day before was intubated. He was failing mechanical ventilation. He had failed non-invasive, failed mechanical ventilation. His pH, we couldn't get above 7.2. We brought him, I put a cannula in, went to a low-flow ECMO device for CO2 removal. The next day he's up and walking. This is critically important to maintain for these COPD exacerbations. It's a 25% mortality. 50% of those patients end up in a nursing home after this type of exacerbation. So there he is, next day, eating. Ivan has become a dear friend. So management improvements, management protocols, it really boils down to doing it the right way. You've got to have a good anticoagulation protocol. We've revised that. I've rewrote that initially about 4 years ago for our hospital-wide system. I've revised it twice since then. Strict transfusion policy, strict ventilator management, and sedation and physical therapy policies. So obviously you have the goal of balancing thrombus and bleeding, but it's been a paradigm shift. I remember the first time I proposed to change anticoagulation in these patients, I could not name the number of people that came into my office telling me how many people I was going to kill, but that's not appreciating the technology that's out there now. We run a PTT 40 to 60 seconds, and many times we just turn the anticoagulation off altogether, depending on whether we have to do a procedure or for other reasons. So hemoglobin, we're very parsimonious about transfusion. We avoid it at all costs. I have a patient, the patient that's going for her transplant today has a hemoglobin of 6.5, but we are meeting her physiologic needs, and that's what you have to focus on. If you're trying to achieve physiologic perfection, you're probably just going to do more damage than good. Physiologic adequacy is all you need, especially in the chronic patient. These patients are used to having the blood gas of the 60-60 club, right? So you do not have to give them a CO2 of 40. You don't have to give them a PaO2 of 120. A PH patient that I have on right now, 34 years old, just a little bit of forward flow, and she's lost 10 kilos in body weight. Creatinine went from 3 to 0.9. They really don't need much, especially in the young organ. Avoid transfusions to the extent that you can. Same with platelets. Sorry for the eye chart. This is old data, but we went from a policy where we're transfusing patients typically around 2 units a day to now, in our most recent series, it's about 0.2 units. And actually, in our ARDS population, hypercapnic patient, we've only transfused 1 unit in the last, I think, 16 patients for all of them, all runs altogether. So where are we going? You know, this is kind of like VADs were maybe 8 years ago, maybe less. Will it completely replace the ventilator? No, and I don't think there's a need to do so, but in hypercapnic failure, this is probably going to be the way to go. You need very small cannulas, you need very small flows. The devices that we're working on right now are probably going to flow somewhere between 300 and 800 cc's per minute. That's essentially dialysis. And the cannulas that you're going to need are probably going to be a little bit bigger than your VASCAth. I could tell you, but then I'd have to, I can't tell you actually because of agreements that I have. But it's going to be small and it's going to work. As I said, we're doing the feasibility trial at Columbia right now and we're about to enter into a larger trial. So destination therapy, obviously a real goal for those of us that do end-stage lung disease work, a lot of it. Portable devices, the devices are much smaller, easy to use. There's obviously, we're working on some new internal as well as external components that are going to be miniaturized. We have to develop good in-hospital management, similar to the VAD floors, and outpatient management as well. So in summary, you know, there's a lot of potential here to reduce the need for ventilators, especially in severe ARDS patients, improve outcomes, and hypercapnic failure is ripe for this. I think thoracic surgeons really should be involved. This is a natural fit for us. You should have strict protocols. You have to adhere to them aggressively. Find a good medical peer. This works best if you're working as a team. This functions because of a team. It doesn't function because of me. It only works because we have a very good, very dedicated team. And early intervention really provides the best results. So you can do this in a lot of bad places. Last year I was in Afghanistan, great place to be. This is ECMO in the austere environment when I was deployed there. This is not even 10 kilometers from Pakistan, up in the northeast portion of Afghanistan. I brought in a device because that's what I do. And this was a polytrauma patient, Afghan soldier that had been hit with an IED. And that's the device that I brought in, the console, pump head, oxygenator. That fit within my gear, and I think that's probably a good segue for Dr. Wright's talk, but a lot of room here. Thank you.